Postoperative varus alignment of an unstable subtrochanteric femur fracture treated with an intermedullary nail has been shown to be related to which of the following factors? 1. Use of a piriformis entry nail through a greater trochanteric entry portal. 2. Use of a greater trochanteric entry nail through a piriformis entry portal. Number 3. Use of a lateral entry nail through a piriformis entry portal. Number 4. Use of a femoral distractor device to obtain a reduction. Number 5. Use of a fracture table to obtain reduction. And the answer is 1. Use of piriformis entry nail through a greater trochanteric entry portal. I will give the reason. The reason is the usage of a piriformis straight nail through a greater trochanteric entry portal will bring the fracture into varus, as the greater trochanteric entry site's axis is lateral to the femoral shaft, and advancement of the nail causes the two axes to become collinear, leading to varus. More regarding a subtrochanteric fracture. Subtrochanteric ST femur fracture are defined as fracture of the proximal femur that occur within 5 cm of the lesser trochanter. Multiple deforming forces act on both of the proximal and distal fragments of the fracture to create a characteristic deformity. On the proximal fragment, the gluteus medius and gluteus minimus causes abduction, iliopsoas causes flexion, and the short external rotators, that is the piriformis, obturator internus, quadratus femoris, and the superior and inferior gemelli causes external rotation. On the distal fragment, the gracilis and adductor muscle cause an adduction and shortening force. The characteristic deformity, abduction, external rotation, and flexion of the proximal segment and adduction of the distal segment is a typical fracture pattern of varus and procurvatum. This picture illustrates the deforming forces, the red arrow of the proximal and distal fragments in the coronal planes. The proximal fragments is abducted by the gluteus medius and minimus 1, flexed by the iliopsoas 2, and externally rotated by the short external rotators 3. In a coronal plane, in the next picture, B is sagittal plane, the distal fragment is adducted and shortened by the adductors and gracilis. Entry to the piriformis fossa. The main advantage is a collinear trajectory with the long axis of the femoral shaft. Entrance portal anterior to the midpoint of the trochanter may result in perforation of the anterior cortex of the proximal femur. Entry that is too far anterior results in deformation of the nail and comminution of the proximal fragment. Entry that is too far medial may result in femoral neck fracture. For nails are designed for the piriformis entry, the lateral placement through the trochanter may cause varus alignment of the proximal fracture. So, the answer for our question just now, entry in the posterior aspects of the piriformis fossa generates least stress in femur. Such placement ensure that the hole will be aligned with longitudinal axis of medullary canal in both sagittal and coronal plane. Excessive medial placement may create a stress riser in femoral neck. It may also compromise the vascularity of the femoral head. Disadvantage of entry through the piriformis fossa is peritrochanteric pain. A report by Dora et al. Cadaveric study. This study shows that with entry portal, A. Lateral to the junction of the neck and the greater trochanter, there will be a partial avulsion of the piriformis and the obturator internus tendon. For B. Entry portal at the base of greater trochanter anterior to align along the longitudinal axis of the femoral neck will cause injuries to the piriformis tendon and to the gluteus minimus tendon. C. Entry portal at the base of greater trochanter but posterior, currently posterior, to align along the axis of the femoral neck at the piriformis fossa will cause a partial avulsion of the piriformis, obturator internus, obturator externus with anterior branches of the ramus profundus of the medial circumflex femoral artery MCFA within the synovial fold will be damaged. The result of this cadaveric study favor the nail entry portal lateral at the greater trochanter. During open reduction and internal fixation of a both forearm fracture, restoration of the radial bow has been associated with which of the following? 1. Wrist extension strength. 2. Wrist flexion strength. 3. Forearm rotation. 4. Elbow range of movement. 5. Reduced incidence of synostosis. And the answer is 3. Forearm rotation. Fracture of both bone forearm are relatively common injuries. Malunion and non-union occur because of difficulty in reducing and maintaining reduction of two parallel bones in the presence of supinating and pronating muscles that have angular and rotational influence. Restoration of length, opposition, axial, and rotational alignment must be achieved if a good range of pronation and supination is to be restored. Radius is a bone with complex angle and curve. The lateral curve is also called the radial bow. It is the most important curve. The radial bow plays an important role in supination and pronation of the forearm where the radius rotates around the fixed ulna. The importance of restoration of radial bow in achieving maximal rotational movement of forearms after plate fixation of fractures both bones forearm. Percutaneous placement of a lateral proximal tibial locking plate that extends down to the distal toe of the leg is associated with postoperative decreased sensation of which of the following distribution? 1. Middle hindfoot. 2. Lateral hindfoot. 3. First dorsal web space. 4. Dorsal midfoot. 5. Plantar foot. And the answer is first dorsal web space. Minimally invasive plating of the proximal tibia provides less extensive surgical dissection and improved periosteal blood flow compared with traditional open approaches. Cadaveric dissection study by Walensky P. et al. 2008, the conclusion. The distal anterolateral approach can be used to place plates along the anterolateral border of the tibia. The superficial peroneal nerve is always seen in the distal incision and is not at risk. The structure at risk are the deep peroneal nerve and the anterior tibial vessel as they cause from a posterior position proximally to a more anterior position distally. Deep peroneal nerve is a terminal division of the common peroneal nerve. It is itself a branch of the sciatic nerve. It arises within the lateral compartment of the leg between the peroneus longus and the neck of fibula. As illustrated. Motor function. The deep peroneal nerve innervates the muscle in the anterior compartment of the leg, including the tibialis anterior, extensor hallucis longus (EHL), extensor digitorum longus (EDL), and peronostasis PT that are responsible for dorsiflexion of the foot. As illustrated, regarding sensory function, the deep perineal nerve terminates in the dorsum of foot as cutaneous nerve. This innervates the web space skin between the great toe and the second toe. As illustrated. A patient wakes up with a foot drop following an open reduction internal fixation of a posterior wall or posterior column acetabular fracture. What position of the leg caused the highest intraneural pressure in the sciatic nerve? 1. Hip and knee extension. 2. Hip flexion to 90 degree, knee extension. 3. Hip internal rotation, knee flexion to 90 degree. 4. Hip and knee flexion to 90 degree. 5. Hip extension and knee flexion to 90 degrees. And the answer is 2. Hip flexion to 90 degree with knee extension. Based on the human cadaveric study by Borelli Jr. et al. 2000, pressure transducer placed within the sciatic nerve distal to the femoral attachment of the gluteus maximus. Intraneural pressures measured with the hip placed in 0, 45, and 90 degree of flexion, while the knee was positioned in 90 degree, 45, and 0 degrees of flexion. The conclusion: intraneural sciatic nerve pressures are influenced by the position of the ipsilateral hip and knee. The magnitude of the pressure elevation is related to excursion of the nerve as the linear distance between the greater sciatic notch and the distal aspect of the leg increase. Intraneural tissue fluid pressures measured within a localized section of the sciatic nerve appeared to exceed critical threshold for alteration of the blood flow and neural function only when the hip was flexed to 90 degree and the knee was fully extended. Which of the following amputation will lead to the greatest oxygen requirement per meter walk following a prosthesis fitting? 1. Above knee amputation or transfemoral amputation. 2. Through knee amputation. 3. Below knee amputation or transtibial amputation. Number 4. Sime amputation. Number 5. Midfoot amputation. And the answer is 1. Above knee amputation or transfemoral amputation. For unilateral transfemoral amputation, study shows that patient had a self-selected walking speed 8.6% slower than their non-amputee counterparts. Another study showed a 49% increase in oxygen consumption during ambulation in patients with an above-knee amputation. Approximately 65% more energy expenditure is required to ambulate in above-knee amputees when compared to patients without an amputation. This number can increase to 100% when the amputation is performed due to vascular compromise compared to trauma. The pelvic spur sign on plain radiograph is pathognomonic for which of the following injuries? 1. Transtectal transverse acetabular fracture. 2. Vertical shear pelvic ring injury. 3. Displaced H-type sacral fracture. 4. Both column acetabular fracture. 5. Anterior posterior type 3 pelvic ring injury. And the answer is 4. Both column acetabular fracture. The spur sign is seen on the obturator oblique view and define this fracture as an associated with both column fracture. Obturator oblique radiograph is obtained at 45 degree to the coronal plane with the injured hip raised and with the center of the beam on the center of the femoral head. In the perfect view, the anterior superior iliac spine ASIS and the posterior superior iliac spine PSIS is superimposed, seen as the iliac cross-section is as small as possible and obturator foramen as large as possible. The coccyx should be at the center of the femoral head.